I'm going to talk about managing the common problems that we see in children with HIV. Just a disclaimer, this is not an academic treatise. This is basically based on my years of experience. I'm not an academician, I'm a clinician. It's based on what I've seen in the clinics and what I've seen in my rooms, seen in the wards, and how we manage to treat patients. So don't expect, I got a bit embarrassed because I saw last month Dave Spencer had all the references underneath. Don't expect that tonight, okay? This is just practical issues. Okay, so there's two main patterns of disease that we see in kids. And that would be your rapid progressors and your slow progressors. Rapid progressors, these are the kids that you see in the cover of Time magazine, tiny, shriveled up. Often they've got encephalopathy, so they're obstetronic and stiff. And they get sick very early on in life, and with really bad illnesses. They develop OIs, PCP, CMV. They can often have encephalopathy as well, failure to thrive, and there's certain characteristic disease manifestations, which we'll talk about. And without treatment, they will die by the age of 2. Your slow progressors are somewhere in between your rapid progressors and your adults. Adults totally asymptomatic. Slow progressors not asymptomatic. They do get sick, okay? But it's relatively minor stuff. Things like, if you can call it minor, pneumonia, sinusitis, that kind of thing. They usually grow well, although they're very often short. I've always said, if you want to screen for HIV in school, kids just line them up in terms of height and test the 5 shortest kids. You'll get it right every time. Because often their weight is not bad, but they certainly are short. They have characteristic disease manifestations, which we'll talk about, things like parotid, LRP, absolutely characteristic of your slow progressors. And without treatment, they can go 5 to 6 years, sometimes even longer. I've got a 17-year-old who's still not on ARVs yet. So they can do very well without antiretroviral therapy. So sometimes it's important to try and characterize the child you're dealing with, because it becomes a lot easier then to sort of work out what you're dealing with. For example, if you see a child with a miliary picture on X-ray, that could either be miliary TB or LRP. But if you know this is a slow progressor, it's more likely LRP. If it's a rapid progressor, it's more likely miliary TB. So it does help you to sort of characterize which mode the child is presenting in. Right, so the common conditions that we see, I've never seen this classification anywhere else, but as I see it, the common conditions that we see, 2 main groups. Yes, you do get your true opportunistic infections, which occur only in people who are immunocompromised, but far more than that are your normal common childhood infections. Remember, children get sick. I'm a pediatrician. Before HIV, I've still had a livelihood, okay? Children get sick. They get sick all the time. It's just with HIV, they get sick often more severely, more frequently, and sometimes atypically. So they will get the same kind of conditions, and that is a very big group. And we'll look at both of those groups. We'll start off with our common childhood conditions, and then look at the true opportunistic infections. So let's go over some of the common conditions. The first one, which is really, really, really common, would be your subacute otitis media. I'm not going to go through this list now, but these are the things I'm hoping to tackle. It's not an exhaustive list, it's just the common things that we see, and hopefully I'll give you a little bit of insight in managing these things. Also, I can't go too much in pathophysiology unless you really want to go until midnight, but we'll stick with the management. So let's start with the ear problems. These are the kids that come in with these green discharges from the ears. I'm sure those of you who have ever been in a pediatric clinic will see them and recognize them, and very, very common. And they just do not respond. You will put them on all sorts of antibiotics, they do not get better. You'll try ear drops, it just doesn't respond. If you look at the ENT guidelines, they'll say ear drops work, but in order for them to work, you've got to take a suction device and suck out all the green gunk and then put the drops in. It's totally impractical. Nobody can do that or does that. So what do? The problem is that your oral antibiotics don't work. Why don't they work? Because by the time it's chronic, you've got Pseudomonas, okay? And Pseudomonas, as we know, does not respond to any of the common childhood antibiotics. The only oral antibiotic that works would be your ciprofloxacin. But there's a big warning, don't use ciprofloxacin in kids. So I just want to tell you a little secret. Okay, ciprofloxacin is only a problem in beagle puppies. Beagle puppies get sore joints. So when the pharmacist phones me up and says, "Doctor, do you know that this child is under 18 and you can't use ciprofloxacin?" I say, I checked, it's not a beagle. So it's fine, we can use the ciprofloxacin. So that's true. Just to give you an example, in 2003, in the United States, there were 6 million scripts for ciprofloxacin in children under the age of 18. Now, if they can use it in the United States, where they'd be sued left, right, and center, we can use it in little old South Africa. Also, there's a syrup. Have you noticed? There's a ciprofloxacin syrup. Why would you bring out a syrup? I was told it's for adults who can't tolerate tablets. So my advice is don't use it willy-nilly in every single child who comes in with an ear infection. But if you have a patient who you've got this chronic discharging ear, you've tried the normal amoxil and augmentin, that kind of thing, it's not getting better. If you want to be a purist, send an ear swab off by all means. But if you don't have that access to that in your clinic, just put them on ciprofloxacin. Really, there's pediatric dosages, and that's the pearl in terms of this. Go for the ciprofloxacin and don't stress about the joints. Okay. Seborrheic dermatitis, I'm afraid, doesn't project all that well. Very common condition. In young babies, we call this cradle cap. Most babies have got little flakes in the scalp. Not a big deal. But kids with HIV can get it really bad. And it's characteristic, this is greasy, waxy kind of flakes that you get. These kids are covered from top to toe. In fact, I think this kid was an iris. Got it worse, once we started the antiretroviral therapy. Now we know that seb derm is an allergy against a normal commensal fungal that lives in the skin. Because it's an allergy against the skin, you can either treat the allergy, it's an allergy against the fungus, you can either treat the allergy or you can treat the fungus. So that's how you manage it. The problem is nothing works. So just to take you through it, I've been told by the dermatologists, and I believe it because I've used it myself, that the best thing for managing the dryness of the skin is good old UE, or angemulsificans. Aqueous cream doesn't work, unfortunately, and most people get. But UE, it's been available for years and years and years. It's available in all the clinics. The only problem I've found is if you work at a clinic, you prescribe UE, they'll give you a tub this big, which will last for half a day. You need to get a big 500-gram tub. But what you do is you use it as a soap, and after the bath, you smear the baby from top to toe with the cream to trap the moisture in. Okay, works for atopic eczema as well. So when you pick them up, they slide out of your arms, and you put enough on. That works like a dream for the dryness, because they all have dry skin. And then you can either treat the was it supposed to be a comedy show? You treat the allergy with topical steroids, or you can use topical antifungals. I find an antifungal shampoo works pretty well. This shampoo or Selsun, any of those. If it's not on the scalp, you can sort of spread it to the area where it is, leave it on for 5 minutes, do it twice a week. But often in kids with HIV, I find nothing works. Now, I'll just take you back many years ago, probably about 14 years ago. We just started the HIV clinic at the Gen, the PEDS clinic, and it was me and Shabir Mahdi, used to help me occasionally. We were busy seeing kids, and in walks a child with a letter from the dermatologists. Now, it doesn't work like that, I'm sorry. We refer to the dermatologists, not the other way around. So I get this kid that, please help. Severe seb derm, not responding to anything. So Shabir said, you know what, it's a fungus. Let's just try griseophobia. We've got nothing to lose. Put this child on, the skin turned to absolutely normal. Okay, so it's a little pearl that I learned over the years. You obviously don't start with griseophobin, if they've got a bit of cradle cap. But if you tried the other things and nothing's working, 6 weeks you've got to do it, but it works like a bomb. And it's just something to remember when you're really stuck with these kids. Okay, thrush. I don't need to tell you much about thrush. Just to point out that we don't always appreciate the 4 different kinds of oral thrush that we see. We all know the pseudomembranous, the cream cheese in the mouth, but you get erythematous, median rhomboglossatus, and angulitis. I'm just going to point them out. That's, you know very well, that's your pseudomembranous thrush. But then you also get erythematous, pure red patches on the palate, which is thrush, the candidiasis. Your median rhomboglossatus, you have a nice rhomboid shape on a coated tongue, and then of course your angulitis as well. Thrush nappy rash is reasonably easy to diagnose because you get these characteristic satellite lesions. Often it's around the edges, these little dots around the edges. And also it extends into the flexors, which normal ammoniacal nappy rash doesn't, because most babies are flexed. So whatever is causing the rash, the combination of the bacteria in stool and urea and in urine causes ammonia, and the ammoniacal rash doesn't get into flexures because most babies are flexing. But thrush, so this is your characteristic thrush nappy rash. Okay, so management. I don't have to tell you how to treat thrush, but just a couple of little pills. Nystatin works perfectly against the Candida, but yet it does not respond. You use Nystatin, it doesn't. Why? Because it doesn't stick. You put it on, it just washes right off, okay, and you're not getting any effect. So if you're going to use Nystatin, you must do it frequently, and the last thing before they go to sleep at night must be the Nystatin, so at least stays, over a couple of hours of the night. Dactorin oral gel works much better because it sticks. The gel makes it stick. Nappy rash, just a pearl to give you. Nystatin cream works very well, and you can cover that with a barrier cream like zinc in castor oil, but keeps on coming back. Always come back. Why? Because remember, the gut is colonized with Candida, so you treat the rash, gets better, and then dirty nappy, out comes the Candida again. So if you're going to treat thrush and nappy rash, always give them oral Nystatin as well to clean out the gut as well so that you stop it from recurring. Okay, pneumonia, very common as we know in children without HIV, but also commoner in children with HIV. I can't tell you how many kids I've diagnosed with HIV who present with nothing more than just a straightforward pneumonia, no other signs. And I think it's very important. If you get a kid, especially with a good going lobar pneumonia, even if you don't find any other signs, you should counsel them and test them for HIV. Just a few little tips on treating pneumonia. We could talk for a whole hour on treating pneumonia. Remember, 10% on average, 8 to 18% of acute pneumonias are caused by TB. So any child presented with a significant pneumonia, you should rule out and if necessary treat for TB. You'd rule out and treat for PCP in those who are at risk. I'll talk about PCP later on. It's going to turn out to be your young infants and those with a low CD4 count. Those are the ones that you put them on treatment because PCP is really so hard to diagnose anyway. So if they fit in the right age group, you would put them on treatment. Take into account your local resistance patterns and what the child's been on recently. And because most kids with HIV are on antibiotics quite frequently, you would need to go for a broader spectrum than what you would normally. Gastro, yes, we do get organisms that cause gastro in kids with HIV, but by far and away, your commonest causes of gastro in children with HIV are your normal rotaviruses, astrovirus, all the common childhood causes of diarrhea. And the management is really as you would with any child with diarrhea, treating the hydration, treating any infectious causes. There are a couple of pearls I've got for prolonged diarrhea. If it's going on for more than a week, invariably they have a lactose intolerance, so you could take them off a lactose-containing milk. And if that doesn't respond, there's a regimen that goes back many years. It was first proposed by Professor Malcolm Bowie, who's an emeritus prof from Cape Town, and it consists of three agents: oral gentamicin. Okay, remember to do this orally because the dose is 10 times the normal IV dose. So if you write it IV by mistake, okay, you're in big trouble. So it's orally to sterilize the gut because they get bacterial overgrowth with chronic diarrhea. Okay, and that bacteria then unconjugates bile salts, which is toxic to the mucosa, and that's where your cholestyramine comes in, which binds your unconjugated bile salts. And metronidazole was originally in Bowie's regimen to cover things like Giardia lamblia and anaerobes, but then he took it out. But I think a lot of people still put it back in. And I found it's a very useful thing to use in kids where you really can't control the diarrhea. Crypto, remember crypto is a normal common childhood bug. We see it every now and again. They're so-called self-limiting, but it goes on for a good 10 to 14 days. I don't know if they call that self-limiting, but in a child who doesn't have HIV, 10 to 14 days and it goes away. But kids with HIV, as with adults, once they've got it, the only thing that will get rid of it is antiretroviral therapy, of which a PI-containing ARV seems to have some activity against the bug. So that's the only thing that really works. But there is some anecdotal evidence that while you're waiting to get the kid onto ARVs or for the ARVs to work, that azithromycin might work. And it's certainly something to try if you're really struggling with a child, can't get them out of hospital, waiting for the ARVs to work. I've used it anecdotally. It does seem to work pretty well. Okay, warts are very common in people with HIV and without. People always say, where are the warts in this patient? And then I will say, well, where's the normal skin? The little bits of brown are the normal skin, and the rest is warts. The child is covered from top to toe in these plain warts. Here's another child with what we call the Koebner Phenomenon. The dermatologists get very excited with this because there's only about 5 lesions that will line itself up in a scratch, in a straight line. and that they call the Koebner Phenomenon. They get very excited because, you know, it can only be one of 5 things. I think in P's HIV, the only 2 that really it does would be plain warts and Molluscum Contagiosum. And you can also get genital warts as well. Just remember with genital warts, it's not necessarily a sign of child abuse. Obviously, you need to ask some sensitive questions, but don't call out the flying squad. You know what I'm saying? Often these kids are born with it. We know certainly with laryngeal warts in children are not common, but certainly well described, where they'll pick it up in the birth canal and can present with laryngeal warts a couple of years later. And the same thing goes with genital warts as well. So it's not necessarily a sign of child abuse. I find the treatment of these warts is very, very difficult, very difficult. Nothing really seems to work. If you've got a few isolated lesions, you can do, you know, electrocautery or liquid nitrogen. It's quite painful, but it does seem to work. That child with the genital warts, we had about 5 or 6 different operations before we got rid of them completely. Imiquimod, you can try. I have tried it. The problem is that it works by sensitizing the immune system against the wart virus. So if they've got no immunity, it's not going to work. So if you're going to do it, first put them on ARVs, get the CD4 count up, and then you could try. And I must say, I found ART very disappointing. Try it. I mean, that child that I showed you initially, the overseas guy said, don't worry, just stick him on ARVs, you'll see it will disappear. That was 7 years ago, and he still looks identical. He's well controlled, his CD4 count is normal, he's got an undetectable viral load, and he still looks the same. We just really could not get rid of it. Obviously, we couldn't, you know, burn them all off. I mean, the child would have 3rd-degree burn. So it's very problematic still. You can, you know, you try, some things work, some things don't. This is a child with Molluscum Contagiosum. It looks very similar. They are classically in this area around the eyes. The characteristic lesion, which you don't always see, is something like that over there, where you have a little dot in the middle. They call it umbilification, like a little belly button. But they don't always look like that. Sometimes you can see like a cheesy material. When I was a kid, we were told, all you have to do is you squeeze out the cheesy material, and then you take an orange stick, dip it in phenol, and stick it in there, and it disappears. They don't all have that cheesy material, so you can't always do that. It can be really extensive in kids with HIV. This is a child with extensive molluscum around the eyes. Once again, similar kind of modalities for treatment to warts, but yet again, different story completely. Why? Because it gets better on its own. Okay, if the immunity is good, it will get better on its own, and if the kid's immunity is not good, it will get it with ARVs. So it's not really a major issue. I know, let's say that these are all common infections that all children get. My son had it. I went to a dermatologist. He said, look, yes, I can burn it off with liquid nitrogen. It's going to be painful. Or we can leave it till we're gone in 18 months. And we did that. We left it. Yes, we got a few more crops developing, but 18 months, literally to the day, it just disappeared. So, and with ARVs, it melts. It literally melts in front of your eyes. So if the child's got molluscum and they need ARVs, you just put them. The only time I do anything about it is if it's irritating the child. In other words, it's rubbing against the eye or something like that. Yes, then you would have to deal with that particular lesion. Otherwise, it's generally not anything. You just reassure them it's going to disappear either with time or with the ARVs. Shingles, herpes zoster, we know is a secondary disease from chickenpox, varicella. Okay, relatively common, can also be quite a common cause of iris. Management generally is relatively straightforward. We don't have formulations, pediatric formulations for all the other anti-herpes drugs, so generally it would be just acyclovir. But with varicella, the dose is double that what would use for herpes simplex. Herpes simplex, talking about a common childhood condition. People don't always appreciate this. It's a common childhood, very common in private practice. I see these children, they come in with ulcers throughout the mouth, high fever, really sick, you know, don't want to drink. They often get admitted for a drip. It's a relatively self-limiting condition, gets better on its own. And then, as you know, if it does come back, it then comes back as your characteristic fever blister. But in kids with HIV, you will often see recurrent oral stomatitis because they don't have the immune system. Or you'll find, instead of just a fever blister, you'll find blisters on the lips, above the lips, on the nose. Okay, they can also get in the finger. If they suck their finger, they call it herpetic whitlow, quite common with dentists, from working in the mouth. Once again, the management relatively straightforward. Oral acyclovir. Generally, we use it QRD, but I found in an American guideline they use a double dose, so 20 per kilo TDS. Now, just from an adherence point of view, it's a lot easier to give it 3 times a day than 4 times a day. So I find that's quite useful. It seems to work pretty well. Tinea Capitis, we all recognize, ringworm, quite a common fungal condition. But there's another condition we don't always recognize, and that is what we call carrion. Okay, carrion is a boggy abscess of the scalp. Okay, these kids rarely get put on antibiotics. They don't get better. It's another form of Tinea Capitis. And once you've seen a couple, you recognize it. In the beginning, you'll put them on antibiotics, but bring them back. If you get a kid with a scalp abscess, put them on antibiotics, bring them back in a week's time, and if it's still there, you would treat it as a ringworm. The pearl I can give you about Tinea Capitis is that topical antifungals do not work for scalp infections. Okay, the skin is too thick, your topical creams will not get through. If you've got a lesion on the arm, yes, you can try Whitfield's or any other topical antifungal, not a problem. Once it's on the scalp, you need to give them a systemic antifungal, and I find in kids griseophobin works very well. We don't see side effects in kids, very well tolerated. And so you would use it for both your Tinea Capitis and for your carrion as well. And it works pretty well. We've just got to tell the patient that it's a good 6 weeks before it's going to get better. Okay, so that's the common sort of childhood conditions that we see in HIV, in normal kids, but all the more so in HIV. And then I just want to talk about a couple of true opportunistic infections. Let's start with Pneumocystis. Now, I always ask this question, and please don't answer this, but I always say to the audience, who here had Pneumocystis infection when they were a baby? And I'm always the only one that puts up my hand, because we all had it. I didn't say disease, I said infection. Okay, we all had PCP. Remember, it's an opportunistic infection. It doesn't cause disease in someone with a normal immunity. Most kids will pick it up between 3 and 6 months of age, and they shrug it off. It's really nothing, okay? Develop immunity, and that immunity lasts lifelong, unless they happen to develop an immune problem like HIV as an adult. When the CD4 count drops, they then become susceptible to PCP again, and what you characteristically see is secondary pneumocystis infection. But what we see in children is, in fact, primary PCP, meaning they get PCP disease when all their friends are getting the PCP infection and just shrugging it off. So the pearl I can give you here, and the alarm bell that must go off is when you suspect PCP, okay, when the child is between 3 and 6 months of age. It's an absolutely classical curve. That is the time when you see PCP in young babies. So that's what your primary PCP. Can children get secondary PCP? Yes, they can as well. They can as well. They would obviously be older children over a year of age whose CD4 count was fine earlier. They dealt with their primary PCP between 3 and 6 months of age, and then developed their CD4 count dropped and developed secondary PCP. Often in those situations, they've often wasted other signs of HIV. With your primary PCP, very often it's your first sign of HIV. These are lovely, chubby babies, come in just battling to breathe. You can hardly find anything on auscultation. X-ray can even be totally normal, or you can have an interstitial kind of a picture, or this is quite a severe picture. So it's a very non-specific. And what must ring the alarm bells must be the age of the child. If you have a child between 3 and 6 months of age, for safety's sake, we extend it up to a year. Any child under a year, you would worry about pneumocystis infection. They present with difficulty breathing, tachypnea, recession, respiratory distress. They may be cyanosed, and usually you hear very little to hear in auscultation. One of the laboratory investigations, which we don't normally do, but I find very useful, is with LDH. LDH is usually sky high, usually over 1,000. It's not specific. But if you don't have a high LDH, you can virtually say it's not PCP. So I find it a very useful investigation to do. And if you just do an LDH, it's not that expensive. It's not like if you do a whole LFT. So I'm sure you could do it in the state hospital. Management of PCP, okay, is notoriously difficult, sitting with about a 50% mortality rate for pneumocystis in babies. And the problem doesn't seem to be the pneumocystis. Pneumocystis, we know what works against pneumocystis. Okay, high-dose cotrimoxazole is still the drug of choice, yet these kiddies die. So why is it? It seems to be that that I don't know, I mentioned earlier that often these kids with PCP, any CD4 count is predictive. It's not like in adults where it will be a low CD4. They're just picking it up at the time when everybody else picks up their PCP, and they get a major block. But so at any CD4 count, they are susceptible to PCP. But once they get their pneumocystis, that CD4 count just drops. It drops precipitously. And there seems to be some sort of immune block they get with pneumocystis. Because after that, it's virtually free reign. Any bug can invade. And these children get poly-infection. And that seems to be what kills them. If you look at the children that die of pneumocystis, virtually all of them have got CMV co-infection. So that is the first very important thing, is to rule out and treat for CMV. What they did in Red Cross Hospital in Cape Town, where they had, just as we have, major problem, they were testing for CMV, but it took 2 weeks to get a result. And by then the children were dead. So what they said is, okay, fine, we'll do the bloods, and they put them on ganciclovir. Okay, and they stopped it when they got a negative result. And their mortality rate just plunged. Just plunged. These children stopped dying. We can't do that in our normal clinics, but at least we know what we need to do. The other reason to look for CMV is that we know that if they're hypoxic, systemic steroids will help. But if they've got PCP, it worsens the prognosis. So it's another reason to know they've got PCP, because then they're on steroids to stop it. So even if you don't have ganciclovir, we should do it. But the other reason, a very important reason why you need to look for CMV, okay, is because if we don't know it's there, we will not be able to say to government, you know what, we've got a problem with CMV. We need ganciclovir. Because if these children are just dying, they don't even write cause of death is PCP, but if they did, it would be good. It would be fantastic. But no one says. So they say it's PCP, but it's not PCP, because we know that it's co-infection with CMV as well. So very important. And in terms, I'm not an expert on CMV, but generally serology is useless for CMV. You need to ideally do a PCR or a CMV viral load, or you can do a PP65, which is not as good as the PCR testing. But I would still do it even though you don't have access to ganciclovir. The other co-infections they often get will be bacterial infections, especially gram-negatives, including Pseudomonas. So you need to give them broad antibacterial cover, as well as treatment for pneumocystis. I remember once I had a kid, classic CMV, and the child didn't respond, died. And a day after the child died, we got back the tracheal aspirate that it was Pseudomonas. I'd put the child on ceftriaxone, which I thought was quite broad spectrum, but so you need to cover for Pseudomonas as well. We mentioned systemic steroids. There's anecdotal evidence, unfortunately no trials, that surfactant that they use for prem babies with High-Lyme membrane disease does give at least a transient effect, but it may be better, and sometimes quite dramatic. So if you're really struggling to ventilate a child, it's worth trying. Problem is, you're talking about 4,000 rand a shot. So it's not something that's readily available. The problem is, so what it seems with PCP is we're sort of getting a good idea of how to treat it. It's just, unfortunately, everything that we need is financially out of our reach. But it doesn't mean it's always going to be like that, and it doesn't mean that we don't need to learn about it and motivate for these things if we think it's going to help. The next problem is ARVs. When you start ARVs with a child with PCP. When I first started out, you thought these kids were sick. Okay, let's put them on ARVs straight away, and they just curl up their toes and die. They develop a severe PCP iris, and they die. They literally die on you. So we started sort of not using ARVs immediately, with better results, but we end up with a problem with often these kids would get over their PCP, then get transferred to the normal wards and die in the wards, or go home and die at home. So it's a situation where you don't want to start ARVs acutely, but you really want to have them on ARVs before they leave the hospital. Okay, and I'll get the story from the staff in the hospital. We haven't done counselling on the mother, so we can't put the child on ARVs. So I said, well, is the mother going to give the ARVs in the hospital? No. So the sisters don't need counselling. Let them give it. Before the child goes home, you can counsel the mother. So I think that's an important point. And obviously the child then needs to go on to secondary PCP prophylaxis lifelong. TB, I'm not going to say much about it. Obviously we could do a whole talk on TB. You would all recognize this as TB. classical TB. This is one of my teenage patients. Classical TB, he was smear positive as well. But we wouldn't always recognize this as TB. And this is the problem with pediatric TB. It's primary TB, porcibacillary, very few bacilli, so they don't cough up the bacilli. As it is, we know children swallow their sputum, so even if they can get the sputum, you can't get to it. But even if you can get to it, there are very few bugs. Okay, and often this child's got just a wider mediastinum. This is a confirmed case of primary TB. So difficult to diagnose. On the other hand, children with HIV very often have got lots and lots of chest problems, abnormal chest x-rays. So I think we see both in kids, both overdiagnosis and underdiagnosis. Notoriously difficult to diagnose in kids. We see the whole spectrum. You can see a child with spinal TB. There you can see it just literally destroying those vertebrae. This is a child with scrophulodderma, lymph nodes with draining sinuses, tuberculosis. We see the whole lot. I'm not going to talk about TB treatment, just really at the moment, we do standard TB protocol. Overseas, most people are recommending 9 months of treatment. Here we're still doing 6 months. So I would do 6 months, but just be aware that if they're not responding, consider going on longer. But also be aware that there are often things that look like TB that aren't TB. So if they're not getting better, first make sure you're dealing with TB. Second, make sure he's not dealing with resistant TB. And then if you're sure it's TB and it's sensitive and it still hasn't responded after 6 months, then you could continue for longer. As you all know, we would delay ARVs to prevent iris. And if the child is on efavirenz, you can use it together with rifampicin. If the child is on Kaletra, you would add extra ritonavir in to inhibit the enzyme cytochrome P450 CYP3A4 so that you don't have induction of the enzyme by your rifampicin, which then would lower your levels of your lopinavir. Right, so we all know TB, but I think I want to spend a little bit of time on TB's first cousin, Mr. Mac. Now, we have a lot of fun with Mac with the kids, because I say to them, now you've got the big Mac, or Mac is back, or you're going to get another Mac attack, which they invariably do get because they don't take the treatment. But that's the only fun I have with this disease. It is a nightmare. It is a total nightmare to treat, okay? MAC is it's a complex of a number of very similar Mycobacteria. It is a true opportunistic infection, which means it will only cause disseminated disease in someone whose immunity is rock bottom. So once again, the pearl here is when you suspect MAC, when the CD4 count is rock bottom. In adults below 50, kids 2 to 6 years below 75, you don't really see it in the younger kids. For some strange reason, we don't see it in the younger kids. But that must be your alarm bells. Why? Because if MAC is one of those conditions, if you don't suspect it and you don't look for it, you will miss it. Okay. If you have a patient whose CD4 count is 10 and unfortunately they pass away, are you going to say, I wonder what it was that killed them? No, you're going to say they died of AIDS. Okay. You're not going to think that maybe they died of something that was treatable. So we very happily will bury our patients with MAC, okay, unless you think about it. The other problem, of course, with MAC is symptoms and signs are so non-specific. Recurrent fever or prolonged fever, weight loss, failure to thrive, night sweats. I mean, this could be all signs of just HIV, severe HIV, fatigue, chronic diarrhea that can get gut involvement. I mean, you know, wasting. These are all signs of severe HIV or AIDS. Persistent or recurrent abdominal pain. They can get abdominal lymph nodes, and especially MAC iris. I've seen kids with severe abdominal pain where these nodes enlarge. I've had children with obstructive jaundice where the nodes are pressing on the porta hepatis and can cause severe abdominal pain. The only thing that's is quite well known, although it's first cousin to TB, that respiratory symptoms are uncommon, but the rest can be very non-specific. Signs also extremely non-specific and just general signs of HIV. And lab investigations, they always talk about a pancytopenia, but it doesn't have to be. Often it's just an anemia. And who's going to get concerned if you see an anemia of the patient with an HIV of 10, with a CD4 count of 10? You know what I'm saying? So the important thing here must be to have a high index of suspicion. If you've got a child or an adult with a low CD4 count, those are the ones you worry about MAC. Diagnosis, you've got a culture from a sterile site, blood, bone marrow or lymph nodes. It doesn't help to culture from sputum or stool, because all that will tell you that the child is colonized. You need to grow it from a sterile site, and you just use a normal TB Bacteriac bottle. Grows pretty quickly. Usually we have results within a week. It's not like TB that you need to wait 6 weeks. Okay. Sensitivity testing is only helpful for the laboratory. Okay, I'm told that the only one that's useful is macrolized, but they'll offer you the whole, or everything else, and it's a waste of time. You can say, thank you, I'll take the macrolized, but don't do the rest, because the rest doesn't help at all. Treatment, very, very problematic. They need to have at least a new macrolide and ethambutol. You can consider other drugs, although most people would just use the two. You can consider adding rifabutin, cipro, or amikacin. Generally, the macrolides must either be clarithromycin or azithromycin. Clarithromycin causes problems because of interaction with the ARVs. Your levels go up with your PIs and they go down with the efavirenz. So most of the time we end up with azithromycin. Okay? But you're talking about what does Zithromax cost? About 180 Rand for 3 tablets. So talking about 1,800 Rand a month just for the one drug. So it's a very expensive treatment, plus your ethambutol, plus your ARVs. And you've got to go on for a long, long time as well. So problematic, major, major problem with adherence. Major problem. I really battle to get these kids to take the MAC treatment plus the antiretrovirals, plus of course they're on cotrimoxazole as well, plus multivites. Really a big problem with adherence. Just like with TB, you would want to wait 2 weeks or so to prevent iris before starting antiretroviral therapy. I'm not going to go through the doses now. In the old days, it was lifelong treatment because once you had MAC, you could not get rid of it. Now it does seem like if you can get immune reconstitution, you can stop the MAC treatment. The recommendation coming from the United States guidelines is if they're over 2 years of age and they're on stable antiretroviral therapy, meaning that their CD4 count is suppressed and their CD4 count is, viral load is suppressed, CD4 count is going up, minimum of 12 months treatment, okay, for MAC. And the CD4 count must be above 100 if they're over 6 years of age, or above 200 if they are 2 to 6 years of age. Sometimes it won't be above 100, by a year of treatment. So sometimes you need to go longer. So we're talking a long course, very, very problematic. Once again, it's a kind of condition we know what to do, but we're still far from doing it well. Very, very problematic, difficult disease to treat. But once again, if you don't look for it, you won't find it, and we need to look for it. If we look for it, we can help these patients. They're not going to die with CD4s of 10 from their MAC if you diagnose it and treat it. LRP is a very interesting condition. You do see it occasionally in adults, but it's a characteristic condition of your slow progressor. Very difficult to distinguish from miliary TB. It doesn't project all that well, but you see it looks identical. Here's a CT scan. You can see the little nodules throughout the lungs. Identical to miliary TB. And that's a problem. And invariably, these kids have all been on TB treatment. I mean, in the old days, before people became aware of LRP, I used to find these kids referred from TB hospital. Please help. Been on TB treatment for 18 months, still no response, And there was no TB, or if there was, it had been treated long ago. So it looks identical to miliary TB, but these are often your older children, your slow progressors, whereas miliary TB is very often children under 3 years of age. Kids with LRP are often asymptomatic or reasonably asymptomatic, whereas kids with miliary TB are often a lot sicker. But then again, there is overlap, and you can't always distinguish all that well. Usually older children, they may have clubbing the fingers, but they may not. I've heard people say, no clubbing can't be LRP. I've seen plenty LRP without clubbing. They can have parotimomegaly. Remember, they have these lymphocytes deposited throughout the body, so they can have lymphadenopathy with it. They can have hepatosplenomegaly with it. Often asymptomatic. If they do have symptoms, it'll be dyspnea or core pulmonale. Like I said, X-ray looks like miliary TB. When I was a kid, we were told, don't worry, it's a good prognostic sign. If children get LRP, it's a good prognostic sign. They do very well. And it's true, they were your slow progressors. They did do pretty well. But the problem was that they're predisposed to recurrent pneumonias. And these kids end up with recurrent pneumonias and end up with chronic lung disease, which then is a difficult disease to treat. So any child who's got good going LRP needs to go on to antiretroviral therapy. It will get better on its own if you don't treat them with ARVs, because as the CD4 count drops, so they lose all their lymphocytes. But once again, you don't want to get into that situation because often by that time they've ended up with chronic lung disease. So as I say, any child who's got LRP would go on to, should go on to antiretroviral therapy. And it literally melts. It's an amazing thing to see how it just disappears. I showed you the pictures. There's a clubbing of the fingers as well. So your management, par excellence, is antiretroviral therapy. We used to use steroids in the old days when we didn't have ARVs. I certainly wouldn't use a long course like we used to use previously, but there may be a place for a short course of steroids while you're waiting for the child to get out of hospital, if they're still hypoxic, while you're waiting for the ARVs to work. There may be a role for a short course of steroids in that situation. Parotid often goes together with the LRP, but it may not. Also, a disease primarily of your older child, the slow progressors. Here's an older child we can see with really massive parotid. By the time it's this big, invariably they've got cysts there as well. Okay, it's very easy to diagnose with a sonar. You pick up the cysts. Usually bilateral, usually asymptomatic, although sometimes they have cysts enlarging rapidly, things like that. They can have pain, can get bigger and smaller. Looks like mumps. I mean, I had one kid that every time she got a new teacher, she got sent home for having mumps. You know what I'm saying? So eventually I gave her a note to say, please note this child does not have mumps. You know. The problem we have with parotid is often these children are totally well. CD4 counts are fine. It's a stage 2 disease, so it doesn't need antiretroviral therapy. They're clinically well. They don't need ARVs. But you get a child like this, it's disfiguring. They get teased. Okay, in fact, this child, the teacher worked out what was wrong with him. He was getting all embarrassed and traumatized. And so we actually went for ARVs just for the psychosocial well-being of this child. What I did do with this child is I put him on a PI regimen. We gave him 3 months of treatment. So I used a PI so that you could stop it without developing resistance. Gave him 3 months of treatment, it disappeared. Then I stopped the ARVs. And I said to him, you tell me when I'm going to start it again. And it did come back slowly. It took about almost 2 years to come back to a degree where it was significantly enlarged. And at that time, actually, his CD4 count was starting to drop, and so we put him onto long-term ARVs anyway. But this has changed. When I first started PDG, this was our first case. This is not this patient. And all the overseas guys said, it's cosmetic, don't treat it. And then last year, we did this case, in fact, PDG, and same overseas guys came and said, put him on ARVs. So things have changed, and we're starting to see the whole picture. Not just, say, yes, it's cosmetic, don't worry about it. But no, we must look at the whole child. I mean, what's it good if the child's CD4 count is good, he's clinically well, but yet he's being traumatized psychologically because of his disfiguring parotid. So I think, things have changed. Also, I suppose that drugs have become safer and people are happier to use them with less reason. This is obviously what happens if you don't treat LRP. They get recurrent chest infections and end up with chronic lung disease. Here you can see cysts in the lungs. Looks like a bit of bronchiectasis there as well. Showed quite clearly here on your scan, your cysts in the lungs. The problem is here you've created, not you, but it has been created a new disease. The HIV is relatively easy to treat in these kids, okay, but yet because they've got chronic lung disease, okay, they've got pooling of secretions of phlegm, of sputum, they get recurrent pneumonias, even though their HIV is well controlled. So it's very important that we prevent this by putting all kids with LRP, and even recurrent pneumonias without LRP, onto ARVs to prevent this kind of problem. Because it's, as I said, it's a completely new disease which needs to be treatment. Treatment really, ARVs for sure, and I've seen most of them will recover to a degree, but you need other treatment as well. Physio, and it must be home physio. It's not just a case of come in once a month and let the physio bash them. Let the physio teach the mom or somebody at home to do physio at home. Home nebulizers are pretty good, or you can just even use an inhaled beta-2 agonist with a spacer to open up the airway before physio, so try and get all the sputum out. So regular sputum culture to see what they're colonized with, and then appropriate antibodies based on what they've got. And often you can get things like Pseudomonas. There was a study done fairly recently in Pretoria looking at using azithromycin, not for its antibiotic properties, but for its anti-inflammatory properties. And they found that a dramatic improvement as well. So it's also something to consider. HIV encephalopathy, very sad condition. This is the worst opportunistic problem that we see in HIV. Traditionally, a very poor prognosis. There's two forms. We don't always appreciate that. The static and the progressive form. Static is the common one that we see. These are the children that present with delayed milestones, failure to thrive, shriveled up, very stiff, oppositonic, reasonably easy to diagnose. But your progressive one, fortunately, is very uncommon, but I think it's even worse. This is the equivalent of your adult HIV dementia. It's a child who's developed normally, everything's been fine, they've got a personality, and all of a sudden they start regressing in their milestones and developing motor signs, and quite a sad thing to see. Without treatment, they won't survive more than 2 years of age. And literally, it's cerebral palsy. These children develop a severe form of cerebral palsy. There's a worry because not all the ARVs cross the blood-brain barrier. Do they respond? And I've always had this question, said, is there any point in treating them? They don't respond. So let me show you a few pictures and tell you about a few cases. Now, this is what we call extensor hypertonus. When you pull the child up by his arms, okay, the head flops back and you think he's floppy. He's got low tone, hypotonic. But then you put him on his tummy, and instead of his head flopping forward as it would with low tone, it also goes back. So it's increased tone in the extensor muscles. So it's extensor hypertonus. And this I find is the earliest sign of encephalopathy. Often you have it long before they develop, stiffness and increased reflexes and things like that. So it's something to look for. And very often it responds. If it's mild, it was just this and nothing else, it will respond to antiretroviral therapy. Here's a child, you can see he's grown very nicely on ARVs, done very well, but he's lying down. He can't sit yet. So this is a child who's responded to ARVs, his body's responded, but his brain has not. This is the minority. Very unusual I see the situation. More often I see the situation where the brain recovers. Okay, they might have a slightly lowish IQ, but these kids are reasonably quite sharp. They cope well. These kids are both in special school because they're disabled, but I can have a good conversation with them. They're coping in school. Arms recover, and they get left with a spastic diplegia. But once again, it's a different disease. These children need OT, physio, Botox, tendon releases, all that kind of thing. They do very well, and the parents are absolutely so happy with them. You can't believe how happy they are, because you've literally taken them from being severe cerebral palsy to a child that you can talk to, you can communicate with. They get around. I mean, she's a nightmare on her crutches. She's really fast. She can outpace me on her crutches. He went from a walker to crutches, and then one day he comes to me, he says he wants to show me something. I hope this will work. Let's see if we can get it to work. So what did he want to show me? Hopefully I can show you. Oh, there we go. So there you see he has to hold on to the wall every now and again, and you can see he's still diplegic, but he can walk if he wants to. So and the parents are very happy, and my mind, it's a very rewarding thing to treat. So much so that I had a situation when I was in private practice. I could always tell, although I was seeing everything, I had a big HIV practice, I could always tell if someone had HIV because I just look at the dress. Because I was in the East Rand in Benoni. If I saw they come anywhere out of Benoni, no one's going to travel all that way to see you, for a cold or whatever. So I see this child from the West Rand. So I think, it must be an HIV. I see the child, it's cerebral palsy, what's going on? No, the child had birth asphyxia, didn't cry well at birth, and they've got this problem. So I asked a few more questions, which they didn't give me any more information, so I asked a leading question. I said, what about HIV? I said, no, the child is negative. We did the test 3 times. So now I'm really confused. I said, well, why did you come all the way to the East Rand to see me? He said, no, we had a little child who's in the same play group as our baby, who had the same problem, came to me, and I cured the child. So now, can I do the same for them? So it was really sad. It is funny, but it's really sad. We were told that the brain doesn't recover, cerebral palsy doesn't recover, and yet these kids recover. It's an amazing thing to see. But it's never 100%. I've got quite a few kids that are walking. Some are still on crutches and things like that. One or maybe two didn't respond. But you always have to say to the parents, yes, there will be a response. I can't tell you how much it will be. We have to see with time. Most of the other kids, if they don't have encephalopathy and they get through the first 3 to 6 months, you can virtually assure them of a normal prognosis. But with kids with encephalopathy, you have to be a little bit guarded, say there will be a response, but I can't tell you how much. I can tell you that the parents are so happy with them because really they've been from, I mean, severe cerebral palsy to a child that's, okay, he's disabled, problems with walking, but they're in school, you can talk to them. I mean, he walks in, he says, I want 2 suckers. That's a standard response when he walks in, you know. So you can talk to them. It's completely different to the untreated child, and it's really worthwhile, you know, to treat these kids. But once again, it's a different condition, lots and lots of work involved. Okay, but another problem that we're seeing more and more, and I always say it's a sign of success, because in the old days we weren't concerned. I'm waiting for time. In the old days we weren't concerned, you know, about schooling in these children. We were only too happy if they'd survive a year or 2. But now they're going to school, and all of a sudden we're finding school problems. And these are children who don't have encephalopathy. Some have got a lowish IQ, others don't have a good IQ, and do, you know, have got learning and behavior problems. And basically it looks like any other case of ADD. There was a study from the States showed about 21% of the kids had attention deficit disorder. Okay, it's supposed to be around about 10% in the normal population, unless you live in Sandton, where it's probably about 40%. But we are seeing it, and for some strange reason, it's a condition that if you do not ask about it, I don't know if they feel embarrassed, they will not tell you. They won't tell you this child is struggling at school. And it's the same as parotid-megaly. You know, we need to look at the whole child. We need to start saying, you know what, okay, the ARV is controlled, but how's this child doing at school? What's the point of getting these children to survive to adulthood when they become dropouts? So it's something we need to look at, we need to start treating. Treatment works pretty well. Problems we have in the state sector is that Ritalin is not available in your normal clinic. A child can get ARVs in the normal clinic and got to go all the way to the central hospital to get the methylphenidate. So it is problematic, but it's not insurmountable, and you can treat it. But once again, it's something you must look for. If you don't look for it, you will not find it. And just to finish off with the cancers, fortunately very, very unusual in children. The 2 that we've seen is lymphoma and Kaposi's. Lymphoma, I've seen two in my career. Kaposi's, I've seen quite a few more. Kaposi's in children is different from in adults. They don't get the classic skin lesions that you get in adults. They get what they call the lymphoglandular form, where they present with lymphadenopathy. They can get visceral involvement as well. These cases I'm going to show you now is actually Kaposi iris. And Kaposi iris, to me, is a total nightmare. It's the worst tumor. I've never seen a tumor that grows in front of your eyes. This was a child who presented with a low CD4 count, looked like chronic lung disease, and what to me looked like a lipoma on her forehead. She was a foster child, so they didn't have much history. So I put her onto ARVs, and within 2 weeks she started sprouting tumor all over the body. There you can see one there. This doesn't project all that well, but this whole area here is femoral nodes. She had them on her back, all over, lungs as well. Fortunately, we got her onto treatment, and she survived. She's been off chemo for about 5 years now, and she's done very, very well. This child wasn't so lucky. She presented at a clinic, we put her onto ARVs. 2 weeks later, she developed severe adenopathy in the region of the face. She was battling to breathe. Okay, they did a final aspirate, told her this was TB. TB iris, put onto TB treatment, came to see me 2 weeks after that, literally strangled by this tumor. She couldn't breathe. It was, you can see it's pushed the mediastinum right over, really battling to breathe. Unfortunately, she didn't make it. But the one thing she had, and I found it in every single child, because I look for it, is that classic Kaposi's of the palate, the purplish lesion of the palate. And it's the kind of thing that's high up in the palate. If you don't look for it, you will miss it. So the pearl I can give you here is, if you see a child develops an iris, classic iris, with lymphadenopathy in the facial area, okay, just look at the palate. And if you see a classic Kaposi's lesion there, don't do a fine needle aspirate, because fine needle aspirate will miss it. You need to have either an open biopsy or a true cut biopsy to diagnose the Kaposi's. And as I say, I've looked for every child who's got Kaposi and Kaposi iris. I look and I see the lesions there. It's there. If you look for it, you'll find it. Just to finish off with iris, the commonest cause of iris we see in babies is this, which is BCG. BCG, an interesting disease. When I was a kid, the WHO said, you don't give BCG to symptomatic HIV patients. So it was very easy, because at birth, no one's symptomatic, so we gave it to every single kid. That's how we've been doing it, right? now they've changed their tune. Why? Because we are seeing disseminated BCG, and we're seeing a fortune of BCG iris, abscesses, the right axillary abscess. Once again, if you have a child with a right axillary abscess, that position must be your alarm bell, your pearl, to say that is BCG until proven otherwise. Problems with BCG, first of all, we don't know the extent of, especially disseminated BCG. Why? Because the lab is not very helpful. The lab will tell us if you send a gastric washing or a sputum off, it'll come back as MTB complex. And we all say it's TB, but in fact it's not. MTB complex includes Mycobacterium tuberculosis, Mycobacterium bovis, and BCG. And so I'm sure there are a lot of BCGs masquerading as TB. So if you suspect BCG, you need to tell the lab they must do a PCR for BCG. So I think we're seeing a lot more disseminated BCG than we know about. And the iris is a nightmare because you've got to put these kids onto TB treatment as well. We know that BCG is all resistant to PZA, so they've got to have an extra drug, ethambutol. It's also, a lot of them are resistant to ethionamide, so that doesn't work. You need to give ethambutol. A lot of them are resistant to INH, so you need to give high dose INH. Problematic to treat, problematic in terms of adherence. All the TB drugs, you've got to boost your Kaletra with ritonavir, which tastes vile. So from an adherence point of view, it creates a major nightmare. So as a result, the WHO have changed their tune. They're now saying you don't give BCG to HIV-positive infants. But now we've got a big problem. Because at birth, when we give BCG, we don't know who's positive. So it is a bit of a nightmare. We know that BCG is not a great vaccine. In HIV-negative kids, it won't prevent TB. It will only prevent disseminated TB. So things like miliary TB, TB meningitis. In HIV-negative kids, it's been shown to prevent nothing. So we've got something that we are doing which is causing a lot of harm and not of any benefit to the kids. We've been told by our experts it's too difficult not to give BCG to exposed kids. I don't know why. Practically, it's too difficult. I don't understand this. I'm sorry. I would have thought you just don't give it to any exposed kids. Do the PCR. If it's negative, give them BCG. But as it is in the state, we're trying to work on the experts to try and see, can we maybe pilot this in a few sites to try and do this, because it is really a major, major problem in these young kids who, as it is, don't take their treatment all that well. And it does create a lot of problems. And there you can see that a typical abscess. The management, they say, is not to send it to the surgeons, but to stick a needle in. And don't stick a needle into this nice red area there, because then all you're going to do is create a fistula, which they won't recover. So stick the needle into the healthy skin, aspirate it. Remember, if we can get all kids on ARVs, we're not going to see these kind of things. And I don't have to give this talk, and I have one less talk to do. So please put them all on ARVs, but if they still develop this kind of thing, hopefully this talk has given you a little bit of insight into how to manage the conditions that they get. Thanks very much.